Good afternoon, ladies and gentlemen. My name is Dr. Khaled Sherif. I'm working at EHS. So today in the breakfast, me and my colleagues, actually, we were talking about the presentation. They asked me, what am I going to present today? I was like, Andropause. And nobody knew what is actually Andropause in the beginning. So I think this lecture is going to be exciting. So these are my outlines. And talking about Andropause, I think all of us, we know, men's and women's, we know what is menopause. Even men, as we don't experience menopause, but we know what is menopause. It's a time when there is no more menstrual cycle. It usually happens by the age of 40s and 50s, average 51. And the way to diagnose it is not having a menstrual cycle for 12 consecutive months. But what is andropause? Going back in history and try to analyze it, andro in Greek Latin means men, and pause means cessation. So is it men's cessation? In fact, no, but this is the term they used in the beginning. It was first described in 1946, and it was called at that time as male climacteric, which is characterized by low testosterone level. And one thing to notice is that the difference between hypogonadism and andropause. Andropause, it's a natural occurring process due to aging in which testosterone decreases in our body and then symptoms happen. But in case of hypogonadism, it's a broader term. It's a syndrome in which there is a pathology that affects our whole organ system. Difference between andropause and menopause. As I said, andropause starts by the age of 30, sometimes as early as 28, in which there is a decrease in testosterone level by 0.4 to 1% of our total testosterone level. But in the case of the menopause, it starts by the age of 40. Now, the thing is, the reduction in the testosterone level is very slow, insidious, and progressive. But in the case of the menopause, the reduction in the estrogen level is so rapid, age 40. Does our spermatogenesis affected when we have low testosterone level? No, we still produce sperms. But in case of the menopause, no more eggs is produced. Do all men suffer from andropause? No, but all women at some point, they do have menopause. So if you look at this paragraph, the male testosterone level highest by the age of 28, 30. And as you can see, the aging process reduce our testosterone level, as I mentioned, between 0.4 to 1% per year. Testosterone in our body, usually it's found as bound to something called 6-hormone binding globulin, which is protein found in our body. Only 0.5 to 3% of our testosterone, it is found unbound. We call them free testosterone, and it is the one responsible for the action of our testosterone. Now, the thing is, 6-hormone binding globulin is a protein that binds to the testosterone. As we age, the 6-hormone binding globulin increase. So you can know, we can analyze that the serum free testosterone level, which is the active form, reduced with aging as well. And of course, we would like to note that chronic disease, medication, maybe serious emotional stress, all of them affect testosterone level. So how to diagnose it? Is it only by labs? We measure somebody with low testosterone level, we can say that the patient is complaining from andropause. In fact, we need two important things: symptoms of low testosterone level, and then labs showing low serum testosterone level. Symptoms, it could be fatigue, it could be depression, it could be decreased in libido, it could be erectile dysfunction, you name it. But the most important one, it is low libido. And the problem with an andropause, all these symptoms are not specific for andropause. These symptoms, you can see them in depression, anxiety, hypothyroid, use of some certain medication as well. That's why before diagnosing andropause, we need to exclude all these diseases. As I said, diagnosis should not be made during acute illness, in which decreased testosterone level could be temporarily. And for the minimum criteria, we need 3 sexual symptoms: decrease in libido, morning erection, and erectile dysfunction, combined with total testosterone level less than 11 nanomole, and free testosterone level should be less than 22. And then we can call the patient he's having andropause. Some of them use something called aging male symptoms. It's not very specific. It's actually a questionnaire We ask the patient some of the questions. If they score less than 26, then he's not having andropause. If they score between 26 and 37, in this we can call it mild andropause, 27 to 38, moderate andropause, 39 to 49, it could be severe andropause. So what do we do? Patient present with symptoms, fatigue, sexual function problems, and you exclude all other problems like depression and anxiety and all other things. Number one thing we do is we have to measure serum testosterone level, and it should be between 7 and 11 a.m. because serum testosterone level varies during the day due to the circadian rhythm. Once we know that the patient having low serum testosterone level, and then we can do free testosterone level, which is the unbound form. Why we do it? Because sometimes SHBG could be affected, could be high, which decrease the serum testosterone level, like in case of obesity, an HIV patient, and some of the medications. After establishing that, we know the patient is having a problem with the testosterone. We need to know, is it primary or secondary? That's why we're doing next is LH and FSH. Elevated LH and FSH suggest primary hypogonadism. If LH and FSH was normal or even low, in this case, we have to look for something else. In this case, we have to do some more lab investigations. For example, prolactin, ferritin, maybe semen analysis, and sometimes we need to look for tumor. That's why we have to do an imaging, like an MRI. So does anybody receive testosterone replacement therapy if he's having symptoms? Or let's say he's having only labs? No. Two important things, symptoms and low serum testosterone level. In fact, endocrine society, they're just against giving testosterone to a patient without symptoms, but showing he's having low serum testosterone level. But before that, we need to make sure the patient doesn't have any other problems. For example, we need to measure his PSA. If it was 4, and then he should be to refer to a urologist. If his PSA was more than 3, and he's of African-American descent, or let's say he's having first-degree relative with prostate cancer, he needs to be referred to a urologist. And then we need to know one important thing, which is hematocrit. It should not be more than 48. Why? Because testosterone going to increase erythrocytosis and so increase in hematocrit, which may lead eventually to a problem with a cardiovascular event or even maybe stroke. So what are the testosterone benefits? If you went to any of the anti-aging clinic, they're going to tell you it's an elixir drugs. You can use it, you can be happy, you can be strong, you're just going to gain muscle and decrease a lot of fat. Is that true? So they've done a trial, which really, I think, really interesting. It's a multi-center testosterone trial to test 1-year efficacy of testosterone sexual function, physical function, vitality, cognitive function, anemia, bone density, and cardiovascular risk factors in older men with symptoms of hypogonadism with consistently low testosterone level. So the inclusion criteria, they should have low testosterone level, less than 275, and symptoms suggesting hypogonadism, or let's say andropause, and they should receive testosterone for 1 year through gels. 51,000 men were screened, and only 788 men who met the criteria. Testosterone concentration average at the beginning was 232, and after 1 year after receiving testosterone replacement therapy, their testosterone level was 500 nanogram per deciliter. So what are the benefits? Definitely decrease in fat, increase in lean body mass, with no overall change in the body weight. Sexual function, yes, improvement in sexual desire and libido, but there was no change in erectile dysfunction. Physical function is actually interesting. No significant difference between walking distance on 6-minute walk test and the 390 men who were enrolled in the physical function trial. But they did improve in walking distance when all of the candidate, the sample, 788 men, were included. They found that testosterone replacement improved it. Vitality, through something called functional assessment of chronic illness therapy, fatigue scale, which is this one. They do ask a patient a lot of questions, and then they found he's having the symptoms or not. They found it did not differ between placebo and the testosterone replacement therapy. But one thing to mention, they report better mood and lower severity of depressive symptoms. Cognitive function, tested age-associated memory impairment. It was based on subjective memory complaint and objective memory performance, lower than the younger one. And after 6 to 12 months, there was no difference in test score for delayed paragraph recall, visual memory, and spatial ability. The only thing they found, they improve in executive function. And some of them believe that because testosterone convert to DHT and DHT can improve the neurofunction. That's one of the explanations. Other benefits is among 788 men enrolled in all three trials, 126 of them were anemic, 4 associated with known cause such as iron deficiency anemia, and 62 of them were they did have an anemia but unexplained one. Both anemic groups improved by 1 gram per deciliter after 6 to 12 months. Bone mineral density improved, and this was measured by quantitative computed tomography. So testosterone, obesity, and metabolic syndrome and type 2 diabetes, does it affect it? In fact, they found testosterone has a positive effect on reducing the risk factors for metabolic syndrome and cardiovascular disease, and showed that low endogenous testosterone concentration related to mortality due to cardiovascular disease. Many of the components of the metabolic syndrome could be seen as well in the hypogonadal men: obesity, hypertension, dyslipidemia, impaired glucose, and even insulin resistance. And a lot of epidemiology studies have established a close relationship between obesity and low serum testosterone level. In fact, they found that 20 to 64% of obese men, they do have low testosterone level. And almost 33 to 50% of type 2 diabetic patients, they did have low testosterone level. Based on the previous data, some of them actually suggest screening for testosterone for diabetic patients. Unfortunately, we don't have enough data to support testosterone relation with HbA1c, and it's very premature to recommend testosterone treatment for metabolic syndrome or diabetic patient in the absence of laboratory and other clinical finding of hypogonadism. The effective androgen replacement on LDL and HDL is very controversial. If it was as a testosterone replacement therapy, both LDL and HDL has been reduced. But if the dose went higher, then HDL, which is a protective one, goes low, and the LDL goes even higher. And the mechanism for that was proposed to be the action of androgens on abdominal adiposity. So what about prostate cancer and BPH? No conclusive data that testosterone treatment increased the risk of prostate cancer or even BPH. And there was no evidence that subclinical prostate cancer and clinically prostate cancer could be induced by testosterone replacement therapy. But one thing to mention, it showed that in active advanced metastatic prostate cancer, testosterone replacement therapy can stimulate growth and aggravate the symptoms of the men. Current data are not available to determine whether there is any additional risk from testosterone replacement therapy to lead to prostate cancer. And at some point, some of them, they suggest if the patient was treated for prostate cancer and he's suffering from symptoms of hypogonadism and he's having low testosterone, after some time, we can talk to the patient about testosterone replacement therapy. And the risk and benefit must be clearly discussed with the patient, and follow-up must be particularly very careful. So treatment. Based on the Endocrine Society in 2010, they recommend against general policy of offering testosterone therapy to all older men with low testosterone. They should have both symptoms, low testosterone level, and exclude other causes of the symptoms of andropause. So what is the proper level of testosterone? In fact, Endocrine Society clinical practice guideline panelists, they disagreed on the serum testosterone level below which testosterone therapy should be offered to older men with symptoms. Some of them, through observational study, they found that if it was less than 300, they should start treatment for the patient. Other panelists believe that it should be less than 200 before starting the treatment for the patient. And both of them, they don't have enough data to support their claim, and all of it based on observations. That's why we need more additional research regarding testosterone therapy, when to start it. Delivery mode, many. It could be intramuscular, it could be oral, it could be transdermal, it could be a patch. And one thing to mention that free testosterone half-life is only 10 minutes. That's why all the testosterone, synthetic testosterone, I would say, they're bound to an ester. Ester could be long-acting or it could be short-acting to increase the half-life and to avoid multiple daily dosing for testosterone. At the start, we prefer short-acting testosterone, trying to mitigate the side effect of testosterone. And the aim is, we don't have enough data to say what is the degree, or let's say the serum testosterone level we're aiming for, but we prefer, or they say the therapeutic goal should be between mid to lower young adult male serum testosterone level. And to mention, superphysiological level should be avoided. We can't go above that. Delivery mode, it could be oral. One of them is 17 alkylated, very liver toxic. That's why we should avoid it. Alternative is andicanoate 1. This one, it's not liver toxic because they bypass the first pass metabolism through the absorption through the lymphatic system. It could be transdermal gels. It could be buccal, but the problem is consistency with the buccal. It could be subdermal implants, but the problem here is infection. So these are the type of testosterone that's available in the market. It could be testosterone cypionate, it could be enanthate, and the oral medication, the andicanoate 1, is known as the Anduril. So once you start treatment for the patient, you need to look for the outcome and you need to monitor the patient. It's properly to monitor the patient after 3 to 6 months. And we need to ask the patient regarding libido, sexual function, muscle function, and improved body fat. And if there is no improvement in 3 to 6 months, then we can stop the treatment for the patient. The target value should be between 300 to 400 nanogram per deciliter to lower the risk of testosterone side effects. And every 3 to 6 months, it's important to do some sort of labs, hematocrit, in which hematocrit due to erythrocytosis will increase. And the moment it becomes more than 54, you should stop treating the patient and reevaluate the patient. PSA, if it increased more than 1.4, the baseline, if it was more than 4, in this case, the patient should be referred to urologist. Lipid profile, because some of the alteration, because of the decrease in the HDL, which may lead to some cardiovascular event. And if the patient was given 17 alkylated, in this case, we need to measure his liver function test. So side effects, coronary artery plaque. They found that in a study, they found that 170 men after 1 year of testosterone therapy was associated with great increase than placebo in non-calcified coronary artery plaque. And this was measured through the CCTA. The problem, or let's say the limitation of this study, it was a small size, short duration, and they only used CCTA. Erythrocytosis, in fact, this is one of the most common side effects of starting testosterone replacement therapy for the patient, and it is the main reason they stop or discontinue testosterone replacement therapy for the patient. Cardiovascular risk, very conflicting. Some epidemiologic studies suggesting no increase in cardiovascular events, and others suggest possible increase in cardiovascular events in some men who take testosterone. But for the safety, it was labeled by the FDA that it increased risk of heart attacks and stroke associated with testosterone use. In fact, they've done a study in heart failure patient, controlled heart failure patient. One of them, it showed that it increased in the functional capacity, muscle mass, and decrease in the fat for the patient, and it did not affect other parameters, including hypertension and electrocardiogram. The other meta-analysis, it showed no difference between the placebo and the TRT treatment for the patient. That's why it's very conflicting. One thing to mention as well is that the moment you induce or introduce a testosterone replacement therapy, you're shutting down your endogenous testosterone. That's why you should have a real talk with a patient, let's say in the middle age, who's interested in fertility. Because in this case, at the moment he's taking the testosterone, synthetic one, he's going to be infertile most of the time. But good news, the moment he stops it, 70% of them, they gain fertility again. And probably it needs like 6 to 12 months. And this is the process, how shutdown happens. LH and FSH activate or stimulate the testicle to produce testosterone. And the moment you introduce synthetic testosterone, this whole system is shut down. Contraindications, active prostate cancer should not receive that. Palpable prostate nodule should not get TRT. If the PSA was more than 4 or more than 3, in case of African Americans or first degree relative with prostate cancer, should not get that. BPH, it's a relative contraindication. If a patient has a hematocrit of 50 to 51, he should not get that. He should not be receiving testosterone replacement therapy. If the patient having untreated OSA, this will increase in hematocrit, increase in oxygen demand, and may increase in the metabolic demand, which is contraindicated. Uncontrolled, poorly controlled congestive heart failure should not be started in treatment. And that's it. Yeah. I got one more slide, but
Oh.
okay, that's it.
Okay, thank you, Dr. Khaled.
Thank you.